Okay, our last class is next Monday, and so this week I'll be preparing the final, and it will be multiple guests, and there's one question from each lecture, and it's going to be posted online next week, hopefully right after class. So today we have Matt Young from the Frederick National Lab, and he's in the Laboratory of Cancer Prevention. He's going to talk to us about diet and cancer prevention, translational research in colon cancer. Matt.
Thank you, Terry. So thanks everybody for coming back from Thanksgiving. Hope you all had a happy couple days off. So who overate in Thanksgiving time? Yes, which is good that you're admitting it. Who had maybe had a few too many to drink during Thanksgiving time? So who's not raising their hand because they don't want everyone to know that they overate and had too much to drink? So that's one of our problems with doing dietary translational research or studies, is that people won't admit, either to the researchers or even to themselves, what they've eaten, that they've eaten too much, or that they're off their diet, or drinking too much. So what I'm going to talk about today is how we do translational research with dietary interventions. And we're going to focus on colon cancer because that's where my work has been focused in. But how we do translational research sort of spans across all types of dietary intervention studies. This is the prevention cage. This is where the mice are much happier and really want to be. They're fed diets that are rich in fruits and vegetables, some red wine, of course, and garlics and spices, and some tea when they want it. So obviously this is a nice, healthy place to be. So on the menu today from the prevention lab, the prevention cage, is we're going to talk about doing translational prevention. We're going to now give you some talk about the colon cancer, the anatomy of the colon, and some of the risk factors, and then some of the colon prevention trials that we've worked with, and how you might do some dietary interventions. What we're doing with our mouse models, how we're using metabolomics and now some microbiome analysis to learn what's going on. And flavored in amongst all of this is some stem cells, because all of this is probably affecting stem cells and our nutrition. To start with, you need to know what drives tumorigenesis. So tumorigenesis is a multi-stage event, starting with the initiation, which is a DNA mutational event that can happen anytime in your life, and usually a single event, but it can be multiple events. Followed by the promotion stage. The tumor promoters are agents that will drive these initiated cells into a benign tumor, and this is the rate-limiting step. It can occur over many years, but eventually you get a benign tumor, and some of these benign tumors will progress into carcinomas and invasive tumors. As I said, the promotion step is the rate-limiting step. If you think about HPV or cervical cancer caused by HPV, the initiating event occurs early in life, in the late teens, early 20s, which is the infection with the virus. The tumor promotion event occurs later in life, 20, 30 years later. So this is a broad time frame in the adult. Hitting the wrong button, sorry. The tumor promoters will also maintain the initiated cells in a stem-like or self-renewing phenotype. A lot of our cytokines and growth factors will keep these cells happy as a stem cell population. What are tumor promoters? They're growth factors, hormones, UV radiation, stress, cytokines, and of course things that we consume in our diet can promote tumorigenesis. They generally feed through receptors in the membrane, and they activate the signaling kinase path cascade, which goes through protein kinases, to transcriptional regulations in the nucleus, to translational regulations of the mRNA, and finally to misregulated proteins. But more recently, we're finding that these events can be circumvented. Specifically, one part of our diet, we can create DNA methylation and DNA damaging events without passing through the kinase pathways, as well as some of these protein kinases will regulate translation. So for translating cancer prevention, so how do we do that? Have any of you been in a prevention trial or practiced cancer prevention methods? So it's a broad topic. We do it every day. And a lot of this is consequences of studies that have been using to convince us that these are good practices for our health. Obviously, smoking cessation is a key for preventing. There's a lot of studies that went in to how do we tell our audience or our children or our population that smoking is bad, and how do we stop them from smoking? And this was very successful in reducing the amount of tumors or cancer we get from smoking. Weight reduction, diet modification, exercises. It's very hard to convince people to change their lifestyle and do these things all the time. And there is a lot of research that goes into how do we convince the population to change their lifestyle. When we get into risk factors or groups that have a high risk factor, then we can start using drugs or intervention therapeutics. Tamoxifen has been used for a while now for people that are high risk for breast cancer, but have not necessarily progressed into the tumor stage, and it works very well. DMFO and Sulindac is being used to prevent colon cancer. Patients that are at high risk for colon cancers have recurrent polyps but have not progressed beyond that. Aspirin for breast and colon, the NSAIDs, that actually works in the colon cancer for people that are high risk, as long as they don't have the cardiac side effects from the NSAIDs, and of course then some diet supplements. And the last another mechanism is vaccines. This works very well for preventing cancer. It's probably our most preventive mechanisms that we have. You can, with the HPV virus, we can prevent the initiation event from happening. By preventing that, we never progress beyond that stage. And the HBV is also out there preventing the liver cancer. Finally, antibiotics can be used to treat bacterial infections that can generate tumors. The H. pylori in gastric cancer is a big problem that is easily solved by antibiotics. So colon cancer, it's the third most common cause of cancer-related deaths, and this was 2012. So this is it still stays up there fairly high on the top of the list. It's not a pleasant disease once you get past the early stages. So we really need to work on this. The risk factors, there's some race factors, whether it's genetics or diet, we'll talk about a little bit. Histories, inflammatory diseases. The biggest one, though, is obesity. So obesity is a strong risk factor for colon and many cancers, but specifically for colon cancer. And what we're seeing is a rise of obesity in the US, which this is over the last 10, 15 years. So what you could predict is that we're going to have a rise in colon cancer over the next, as this population of people age into the 30s and 40s. Colorectal cancer rates, the 5-year survival is 90%. So if we can diagnose colon cancer early, before while it's at the local stages, before it progresses, we have a 90% chance of preventing it from progressing further. The problem is only about 40% of the population is diagnosed, or the cancers are diagnosed at this stages. And these are US statistics where we have good medical care and insurance so that we can go beyond the early stages. So how do we get around this, or how can we move forward with this? So this is why prevention is the key for colon cancer, is if we get it early enough, we can prevent it from progressing to a stage where we cannot treat it. Once you pass beyond this localized stage, the 5-year survival rate drops down to 15–20%. So there's a critical time point where we need to catch them at. We need for early detection. And currently in the clinics, we're using occult blood testing for the stools. It's an indicator. It's a big window, so we often miss it. And colonoscopies. And the advantages of doing colonoscopies is when they go in and see polyps that have developed, they can remove them right then, and we basically prevented it from going further. The problem is we're not catching them all, mainly because people aren't getting these diagnostics done, or some of the tumors are missed during the diagnostics. So what we need are biomarkers, positive reinforcements that changes in lifestyle are good for you, and that by lowering or increasing these positive biomarkers, you will continue to reinforce or continue on these lifestyle changes. The case, in fact, is the cholesterol and the low-density lipids. We know we've got a mark. We have to lower our cholesterol below the level, and every time we go to the doctors, they're going to tell us that. Okay, so that reinforces our lifestyle changes. So that's what we're trying to find and look for in colon cancer. For the anatomy of the colon, these are crypts that define the colon. This is from the small intestines, which are a little bit longer, and from the large intestine. And where the cells start is in the stem cell population with the crypt-based colonal cells. These are thought to be the stem cells of the colon. They're maintained as a stem cell by Wnt ligands and other signaling mechanisms from the microenvironment down in the crypts, in the niche. And as the cells migrate out of this niche, the concentrations of the Wnt signaling is diluted out, and they will differentiate into the transiently amplifying cells. These cells still have the capabilities of dividing, but they have lost the self-renewal capabilities. And once they've differentiated into the other populations of the crypts, they've lost the ability to divide. So no longer dividing. They will migrate up the crypt till they reach the peak, and then within about 7 to 14 days, they will be sloughed off into the lumen and lost. So this is a 7 to 14 day turnaround. So every 7 to 14 days, more cells have to be made. So this is a constant changeover in the crypts. So what we also have signaling is the microbiome, the bacteria that inhabit the lumen of our gut, food and waste particles that are also within the lumen of the colon or of the gut. And these are creating signals, metabolites from the bacteria, metabolites from the food particles that are also signaling into the crypts and into the stem cells, and can affect how these stem cells are changing and how the microenvironment is changing. The microbiome is a hot topic now for colon cancer especially, but many different cancers and how it's being regulated. One disease of the colon is colitis. Chronic colitis is a big problem that can lead to colon cancer, and what they're finding out now is they can do microbiome transplants from healthy donors into people with chronic colitis disease, and they can cure these people or at least stop the disease for significantly long time periods. So the microbiome is a major player in what's going on in the colon. So back to our tumor promotion. The initiation event in the colon usually leads to activation of beta-catenin, either by mutations of beta-catenin itself or mutations in the APC gene that will cause the beta-catenin to be degraded in the nucleus. So with this, you get the benign tumors, the polyps that will develop. And then with chronic exposure to the tumor-promoting agents from the microbiome, from the Wnt signaling and the cytokine expressions in the microenvironment, you can accumulate multiple events. And in the progressed tumors, we see activation of RAS, we see loss of PTEN, and then these tumors will progress into the carcinomas. The stages of colon cancer in the stage 0 is basically what we call the polyps. It's in the mucosal layer, its growth. These are easily removed by the GI doctor under a colonoscopy. When we go to stage 1, the tumors have migrated in the mucosal layer. Again, this is somewhat flexible and they're easily removed. Stage 2 now, the tumors have migrated through the muscle layer and they're into the serosus layers. It gets a little bit more tricky whether how much can be removed from a colonoscopy or whether they need to be removed surgically. Stage 3, they've actually migrated beyond the serosus and started to invade into the lymph tissues in the local areas. So now some would call this actually an invasive tumor once it's into the lymph nodes. And then finally, the stage 4 is where they have spread to other organs, predominantly the liver, the lung, and in the abdominal wall. This is where it's very hard to treat. And this is, as most stage 4 is usually the end. So how does our diet affect what we do or how in colon cancer? So if you think this is the normal cell and the tumor promoting agents progressing through tumorigenesis, our diet provides fuel that we need to sustain life, and overeating or missed diets can create an energy imbalance. And this energy imbalance can drive the proliferation and the inflammation and can drive this to the tumor stages. In addition, what's in our diet, what we're eating, red meat, carcinogens, other components, can directly affect how cells proliferate and drive this stage of it. And finally, if we throw the microbiome in the mix and understanding what that's doing, the microbiome is going to affect the fuel availability, either increasing it or decreasing it, depending on the microbes themselves. The microbes are going to change the food components of what we eat. So what you consume may be altered by the microbes that you have in your gut at the time you consume it. And finally, the microbes themselves can drive or have an effect on proliferation in the tumor cells themselves. So in amongst this, there's a large mixture of what we need to understand about what's going on in our gut that's driving tumorigenesis. And finally, of course, what we eat can affect our microbiome. And so depending on a high-fat diet is going to increase the types of microbes that are unhealthy for us compared to a low-fat diet. So to show this, Stephen O'Keefe did a study comparing Native Americans with African Americans. And I don't know how many saw the Bill Gates talk this morning. This study was partially funded by his studies, or his funds to go in and understand the health components of our children, especially in the third world countries. So what Steve did is he studied the difference between the diets and the metabolome in the African Americans versus the Native Africans. So the African Americans who have a high risk of colon cancer, and whereas the Native Americans have a significantly low risk of colon cancer. And if you look at their diets, the African Americans eat a high fat, a high protein, and a low complex carb diet, typical American diet. Our Caucasians generally eat the same diet, so there's other factors going on, but this is a comparison. The Native Africans, on the other hand, generally eat a low-fat, high complex carb diet. So it's a major difference in the types of diets. Generally, you don't find obese Native Africans compared to the African Americans. And what O'Keefe found was that the bile acids and the metabolites that are generated in the colons, in the guts from these peoples, that the African Americans had a higher level of secondary bile acids that tend to be carcinogenic compared to the Native Africans, and they have a much lower level of the anti-neoplastic short-chain fatty acids. So the conclusions from this study was that eating a high-fat diet, low complex carb diet is going to generate an unhealthy environment in our microbes that may be carcinogenic. Did I miss something? I did miss this. So this is a sort of to draw this out in the American population, where we stand in terms of risk factors. This is the risk rate of population of incidence in the males versus the mortality rates here. And what you see with the African Americans, the incident rates is fairly high. It's among the highest in the U.S. With the Caucasians peaking in early times, but is coming down. This could be insurance. This could be healthier diets. This could be environment or social environments that are affecting this. The mortality rate, though, is significantly higher in the African Americans than in the Caucasians. So there's something different about that. And as I said, probably we're eating the same types of diets. So there's probably a genetic effect. Whereas the African American versus the Native Africans, they're eating a different diet, but they may have a closer genetic relationship. So there's probably a mixture between our genetics and our diets that we're eating. So I'd also like to point out the Hispanic population tends to be at the lower end of the curve with the lowest rates, and we'll talk about that a little bit as we go further. So how do we do studies in cancer prevention? This was while I was at the laboratory cancer prevention. And what we like to do is use population studies as a starting point or to guide us to where we want to go. And we want to use that to find response biomarkers and molecular targets. We'll take them into our mouse models to validate them, to see if there are other markers that we've missed and to do statistics. And then when possible, we can take them into in vitro cell culture type models to look at molecular processing, take them back into the mouse to validate these, and then we can use this to go back and forth to design better clinical trials, as well as to use our clinical data to design better mouse studies. So where did this start? This started back in the 90s with a clinical trial, the polyp prevention trial. This was a multi-randomized controlled trial to look at the effects of low-fat, high-fiber, high-vegetable diets in people that are at high risk for colon cancer. And what the high risk for colon cancer means is when they went in and had a colonoscopy, there was one or more polyps that was in there, and the surgeons recommended that they come back 3 to 4 years later for a repeat to learn whether the polyps are coming back or not. And so this is considered a high-risk population. It's a nice population to do studies in because by removing the polyp, you basically have done all the treatment necessary. So now we can treat them with different diets, with NSAIDs with different compounds over the next 4 or 5 years, and then we can go back in and do another colonoscopy to see if the tumors have come back or not. So it's a nice population to do prediction studies in. And so that's what we did with this study. And in 1996, when they first published this, the results were inconclusive. And basically they said there was no result. The problem was the statisticians, or the authors, included all of the population in the studies, which included the non-compliance, all the people who didn't eat what they were asked to eat, or failed to report properly over 4 years what they were consuming. How many of us remember what we ate 4 years ago? Yeah, so here's an underlying problem to doing these kind of studies. So what Elaine Lanza did is they went back and they re-looked at the data. They threw out all the data from the non-compliers or that was inconsistent with how they recorded the data. And what they discovered was if they grouped them into quartiles of how much dried beans they were actually consuming, dried beans are a high source of protein, a low carbohydrate diet, so a high energy, low index. So what if they grouped them by quartile of how much dried beans they ate? In the men, they found a significant decrease in the amount of reoccurrence of the polyps in these people. So if you look at the data with who is eating and know what they're eating and how long they're eating and how well they stay on track, we might be able to make sense out of the diet. What I find is interesting, this is a fairly large amount of beans per day rate, probably 1 to 2 or 3 cups of beans every day. These people didn't know they were getting better or worse. So there was something in this group of people that encouraged them to continue eating this type of diet over the 3 to 4 year study. So there's other factors going on here. So we took this data and we took it into our mouse model where we could control some of the diets and what's going on. And our first study was in an obese mouse. I told you obesity is a risk factor for colon cancer. These mice have a defect in the leptin gene and they get significantly obese and they eat a lot too. So they have all the risk factors of colon cancer with elevated BMI, resistance to insulin, the obesity, the hypophagia. So it's a good model. And if we treat them with chemical carcinogen, azoxymethane, they will develop tumors in their colon. So that's what we did. We treated them with azoxymethane. Then we started a diet that was enriched in beans or not, and followed them over the course of so many days. And what we found was in the mice that were fed bean diets, whether the whole beans that were cooked, ethanol extracts from the beans, or the residual factors that were left after the ethanol extract, we saw a significant decrease in the number of tumors that were developed. So basically what this is suggesting is that the beans or the bean extracts are reducing the obesity-promoted tumors in these mice. The obese mice were hard to work with. They're very slow, they're very cage confound, and there's other problems associated with breeding them. So we went to a second model, which is a 2-stage carcinogenesis. Again, the initiation promotion idea. The initiation, again, is the azoxymethane. This causes mutations in the colon, generally beta-catenin, activated beta-catenin type mutations, and then followed with dextran sodium sulfate. This is a detergent. It's an irritant to the gut. It causes a strong inflammatory response. So the tumor promoters now are the cytokines and the inflammatory response that are driving the progression or the promotion of these tumors. These mice will develop crypts, aberrant crypt foci, dysplastic lesions, and adenomas, and they're very, very similar to what we see in the human tumors that develop. They have activated beta-catenin, overexpressed COX-2 and iNOS. So these are classic markers. We were able to do virtual colonoscopies in the mice. Basically, this is a MRI imaging, sort of what you could get done in the clinics as well. This is a normal mouse. This is 29 days after the AOM-DSS treatment, and you can see the beginning of the benign tumors appearing. And this is the same mouse over time, so clearly they're developing tumors in this model. When we fed the mice the bean extracts, we saw a decrease in mortality. So the AOM-DSS model can create problems with the mice and they will die. We saw a decrease in the mortality rates, and we saw a significant decrease in the total number of tumors that the mice develop. So we're validating what we saw in the human polyp prevention trial. So we want to know what's going on in the gut or in the animal systemically. So we ran metabolomics analysis. So metabolomics is a systems approach idea where we can follow the metabolites in an organism and how they change with diet or with drug interventions or whatever you have in your study. And in a sense, the metabolites are major markers now of disease. When you go to the doctors and you get a chemistry study, and they report back your cholesterol and your sugars and your glycerols and your low-density lipids. These are all metabolites, and so you get your liver enzymes analyzed by the metabolites that are in your serum or in your urine. So we ran metabolomics on the mice during the study, both in the serum and in the feces, and we were able to detect 430 metabolites in the plasma and 550 metabolites in the feces. And so these are named metabolites, so we know what we can see in these samples. And if we look at this column, these are the mice that have the tumors that were fed the bean diet versus the mice that have the tumors on the control diet. And these are the changes in metabolites that were significantly different. And in the serum, we're seeing 22 that are going up and 47 metabolites that are going down. And more interestingly, in the fecal samples, we're seeing a lot of metabolites going up. Probably from the diet itself. The bean extracts contain a lot of metabolites that the control mice aren't having. But these are indicators, these are possible markers for consumption. We know which mice are consuming the beans by the metabolites, but also possible metabolite changes that may influence how the animal is responding to the tumor promotion stages. One of the classes that I highlighted are the bile acids. And basically, I told you in the O'Keefe study with the native Africans, they had different sets of bile acids than the African Americans. And we see a similar effect in the mice on the beans. We see a decrease in all the bile acids and all the bile acids metabolites, except for this one here. And this suggests that we're changing the microbes to a more healthier metabolism that's more favorable for fatty acid metabolism. And so we're working on looking at some of the differences there. So I told you we like to go from the human studies to the mouse and possibly back to the humans. So we did a feeding study. So this is different than the large population study in that we have a small group of men that were at high risk for colon cancer, and we brought them into the clinic and we told them what they can eat and what they can't eat. And in fact, we gave them their food and told them don't eat anything else. Okay, and so they were, and then we followed the effects of these legume diets over a course of times, and we ran metabolomics on them. So this is the setup of the study. The patients came in, they were either given a diet that was high in beans and low in meat, or a typical healthy American diet, which was the protein source was chicken or fish. Okay, and then we followed the studies. Here's the diets down there. And unfortunately, what we found in this study was when they came in with a very unhealthy diet. So when we put them on a healthy diet, or a healthy diet that was beans, a lot of the biomarkers that we were interested in changed. You could see the healthy diets having an effect on their biomarkers that we were looking at, their serum cytokines and insulins and that effect. So the effects of the beans were minimal compared to that. So when you design these kind of studies, it probably would be better to have a run-in stage where everyone is put on the healthy diet, and then have your variations in your experimental diets. So we did see some effects, and they were reported by Zhang et al. In a couple different papers. But one of the complaints of this study was that the people were complaining that they were full when they were eating the bean diet. And the design was not to have a weight change. So the patients were weighed every day, and the amount of calories they were given was based on their weight gain or loss, so that there was no change in weight throughout the time studies. So if you're eating the bean diet, you had to eat the whole diet as well as the other diet. But the complaint was they were getting full. So they put a last arm on it where they had to eat the beans as prescribed, but they were allowed to eat whatever or not afterwards. And by having this ab-lim diet, they found that there was a significant decrease in body weight over the before and after time, which is about 3 weeks, and a decrease in the BMI on these patients. So what they were seeing is this bean diet is having a weight reduction effect. And they also saw, a decrease in markers of obesity. The cholesterols, the fasting glucose, and the leptins all went down. So this is suggesting that the bean diet is having a healthy effect on reducing body weights and many of the markers in it. So we wanted to know how the bean diets was affecting their metabolites, and if we can compare that to what we were seeing in the mouse models. So we ran metabolomics only on the bean groups. We collected serums before they started the diet, and we collected their same serums from the same patients after the diets were run, and we ran metabolomics on these studies. Not quite as many metabolites as we saw in the mice, a little bit less controlled study, but 87 of the biochemicals were significantly different after eating the bean diets. So we saw at least 87 metabolites changing. Of interest are two metabolites, N-acetyl-ornithine and piperacillin. These metabolites went up in the humans after 3 to 4 weeks of the bean diet, and the same metabolites were up in the mouse serums over the same time point. So minimally, these are markers of consumption that we know that, based on this data, who is eating their beans and who isn't eating the beans. Whether they're actually an indicator of mechanisms, we have to work on that. So other changes we saw both in the humans and the mouse studies, the decrease in the lipofphospholipids, a decrease in medium chain fatty acids, which is suggesting fatty acid metabolism, a decrease in the carnitines and the acylcarnitines. These tend to be associated with high meat diets. And collectively, we're seeing this suggests that it's an increase in the fatty acid metabolism. And the energy that the people or animals are getting from the diet is burning better, is a way of thinking about that. So, I told you in the beginning from the pollen prevention trial that if you ate a high bean diet, you had a significant decrease in the reoccurrence of adenomas. But we don't know who was eating what. We only know who told us what they were eating over the 4 years. So we're now running metabolomics on these patients and comparing it to the metabolomics on the patients who said they didn't comply, or the patients that didn't have a response because they had a low compliance. And we hope to be able to use the biomarkers we got from this study to identify who was compliant and possibly what level of compliance they had, and then possibly learn what other biomarkers may be usable to predict what patients may be having a healthy benefit from these type of diets and moving forward. Okay, so one last quick part. When we go into back to the bench to look at how things are being analyzed and possibly predict mechanisms, from the polyp prevention trial, Garrett Bobie was able to make a correlation to flavonols, dietary flavonols, that are found in beans, fairly high in beans, to a decrease in cytokine productions, or an inverse correlation associated with the adeno reoccurrence, and he's linked it to the cytokine population. Again, this is a clinical study that's done by looking at this statistical data. So we wanted to manipulate or to mimic this in our mouse models. We went back to the AOM-DSS model. We gave the mice the 5 different or 4 different flavonols that we saw, and only the isoremnitin had a significant change in our mice. We saw a significant decrease in tumors, a decrease in the tumor burden, and a decrease in the tumor size. So by feeding these mice the isoremnitin, we're just like the beans, reducing the tumor burden in the mice. So interestingly, in a mechanistic way, we saw an effect on SRC. SRC is an oncogenic tyrosine kinase that's known to be upregulated in many tumors and many drug-resistant tumors especially. And in its active form, it's phosphorylated at tyrosine 419 or 419. In an inactive form, it's phosphorylated at tyrosine 550. And this form prevents its ability to bind to the tyrosine receptors. So what we saw was, in the mice, in the cells, we see a high level of active SRC with a significantly lower level of the inactive phosphorylation events. When we give them the isoremnitin over dose, the active version SRC goes down, and the inactive phosphorylation event goes up. So what we're seeing is that the isoremnitin is phosphorylating the inactive form, putting it into a conformation that's no longer able to be active. And what we and there is a SRC kinase that does this phosphorylation event. And what we're seeing is that the isoremnitin is increasing in the gene expression of this SRC kinase. So why is that important for colon cancer? SRC kinase is, it's not the key regulator, but it's common in colon cancer. So if we look at beta-catenin, I told you beta-catenin is activated in colon cancer, and it's probably the main player. In addition to being a part of the Frizzle-Wnt pathway, beta-catenin is bound to cadherins through this P120 alpha-catenin complex. And the cadherin anchors cells to other cells through this cadherin junction. And the SRC can phosphorylate beta-catenin on a tyrosine, and it will release that from this complex. And what this now allows beta-catenin to go to the nucleus, where it can misregulate gene expression and push more of a stem cell type of phenotype associated with beta-catenin activity. Well, the other side to this is when this complex is disrupted, the cadherin junctions are disrupted, and now these cells are more easily capable of being migrative or able to invade other tissues. So what we saw in the cell cultures is that looking at beta-catenin, we see a significant amount of beta-catenin in the nucleus of colorectal cancer cells. But when we treat with isoremnitin, we lose the beta-catenin in the nucleus. And what we're seeing, if we knock down the CSK, the SRC kinase, this reverses the effect of isoremnitin. So what we're seeing is that isoremnitin is, through CSK, is phosphorylating SARC, which is phosphorylating beta-catenin. And I'm sorry, the isoremnitin is inhibiting SARC by phosphorylating it, which is inhibiting the phosphorylation of beta-catenin, and we lose the nuclear localization of the beta-catenin. Okay, so this is all in cell culture. So we went back in the animals and looked at the phosphorylated form of beta-catenin in the tumor tissues, and what we're seeing in the control diets, a significant amount of phosphorylated beta-catenin in the nucleus of the cells, where a lot of that is gone and are missing in the isoremnitin diet. So now we were able to recapitulate what was predicted from the comparison of the diets in the polyprevention trial. We were able to take it into the cell culture, predict a model, verify that in the animals. We have data that suggests in human colon cancer, CSK expression is lost. It takes a lot more to actually put a causal effect on that. So we'll skip the resveratrol studies. So, and we'll jump to the conclusions. So I showed you that diet and our populations, what we eat, can have an effect on colon cancer and colon cancer risk. And I showed you the difference between the African Americans and the Native Africans. And I showed you data that showed consuming a diet that's high in legumes, high in dry beans, may prevent adenoma reoccurrence in our population studies. And in our mouse studies, we showed that the diets can validate what we saw in the clinical trials. We've showed you some metabolomic data that says that we've identified markers that we can now use in the clinics for compliance to see who is eating what we ask them to eat. Showed you two possible markers there. What I didn't show you is that the resveratrol, which comes from red wine, and you can look at your papers, also prevents the colon cancer, and it's probably preventing this by changing the metabolites that are driving COX-2 expression and ODC activation. And this one is just to remind me, this is the Jeff Gordon's study where they actually are going into Africa and they're measuring the microbiome and the metabolome on different populations of people. And so this is a good reading background for you if you're more interested in the microbiome project. This is a collaborative work by many different labs over many different years, starting in Nancy Colburn's lab. A lot of the work has been done by Garrett Bovey from the Cancer Prevention Division of Cancer Prevention, and being funded by Young Kim in the cancer prevention world. And so we have a few minutes left if you have some questions or want to dive back into other data that I went too fast over.
So have you looked downstream at the EGF receptors? SARC can phosphorylate the EGF receptor as well.
We didn't, so they're actually, whether they're downstream or interactive. Okay. So the EGF receptors can also affect SARC. No, we haven't looked at the effects on the EGF receptors. It might be interested in other tumors that are really driven by EGF. Breast cancer and breast cancer resistant tumors, or drug resistant breast cancer cells, often have elevated SARC that may be being driven through the EGF. And so we are trying to look at that. It's a little bit more complicated because the mouse models aren't as simple. But that's a good point.
Do you think this diet study, like parents and by the diet, had anything to do with genetics?
So the question is that is the variability of the diets a genetic event or a genetic consequence? Yes, most likely. Our genetics determines how we react and respond to the metabolites, to the energy balance, how we produce. Some people are genetically prone to be obese. Also, though, it's the microbiome that we inherit. Okay, so I talked to you about the African American diet. So the president, Obama, is African American, but his microbiome is actually Hawaiian. So he grew up in Hawaii, and your microbiome is you inherit and you develop through your childhood. So the effects of what you're eating has a big effect. Yes, the genetics is also how you respond to the metabolites that you eat. We all know people that can gorge and never get fat. And then we know people who are obese that have significant problems and can diet and have no effect. So yes, there's a genetic event. There's also an epigenetic event. Many of our diet elements are going to affect methylation events, and as well as the cytokines and the inflammation that goes along with that. Yes?
With the human studies with the bean consumption, how were the beans prepared, and was there any difference in whether they were eaten like for breakfast or for dinner?
So the question is on if I understand it right, in our clinical trial where we brought the humans into the labs and fed them a bean diet, how was it prepared? Generally, it was cooked by the lab technicians. They were brought in the morning and they were given a breakfast, but their main diet was lunch, and then they were given a box to take home for dinner. There was a variation of beans in their diets. They were generally just cooked and added into the diet, as you would find in many types of bean, often heavy in Latino type diets. They were asked not to eat anything else, but they went home with a box.
Do you think there is any possibility like of the diet where one is bioengineered food product and one is non-bioengineered food product?
I'm sorry, can you repeat it?
Genetic modified food,
Right.
and one is not modified.
Okay. So the question is, does genetically modifying the food have an effect on our diet, on our microbiome, and on our health? And that's a big open question. You can take it a step broader and ask about how we manipulate our food in itself, and I can bring wheat up as a major component. That we've developed wheat to be disease resistant and weather resistant, and through that development, we've increased the levels of gluten in our wheat. And there's a large population of people that are sensitive to the gluten. Now, there's two types of sensitivity. It's the ability to digest the gluten, and therefore it's a problem with the digestions in the gut. And then there's allergic or sensitivity to high levels of gluten in the serum, which can lead to headaches and other problems. And just removing the gluten can cause that. So yes, there's probably a problem with genetically engineered food, that you are allergic to this component that's put in, and maybe not allergic to that, but people are allergic to peanuts, and people are allergic to shellfish. And so these are just problems that have to be dealt with on an individual basis. Yes?
Transplanting the biome from a healthy subject to an unhealthy subject, is that done orally? Is that...
I don't know the details. In the mice, we do it both orally and rectally. But the mice will eat their feces anyway, so that's not necessarily an unusual situation for them. I think that in the humans it is predominantly through enema or rectal gavage, but I don't know all the details on that. These are patients with severe Crohn's disease or colitis that have tried everything, and they're on the verge of, and it's a very high tumor rate in these people. So this is a happy ending for them.
Okay, we should be moving on.
All right, thank you. One more?
Is there any role for probiotics to modify the
The probiotics and antibiotics will modify the microbes. And that's why we need markers to know when it's good and when you need them and when you don't and when it can be bad. So this is just the beginning time frame on how, but we need to learn when it's good and when it's too much. Good question.
Well, as you know, earlier in the course, we had people go and visit the tumor boards, and at the tumor boards, they discuss cases of various patients here at NCI. So today, I'm bringing the case reports to you. We have Dr. Olatu from the Division of Cancer Treatment and Diagnosis, and he'll be talking about case reports.
Thank you.
There you go.
Thank you, Dr. Woody, and thank you, everybody, for coming. Just going to go through a bit of the objectives. We'll describe the history of cancer case reports, recognize potential roles of case reports, describe case reports, and outline pertinent information for a good case report. This is a definition of case report. A case report is a formal summary of a unique patient and his or her illness, including the presenting signs and symptoms, diagnostic studies, treatment, cause, and outcome. There's been a history of case reports, a long history of case reports in the literature, and Professor Milo Janicek describes it as case reports as the first line of evidence where everything begins. There have been some case reports that have been described earlier by the ancient Egyptian in the papyrus records, and that's where we had the first recorded incurable tumors of the breast. How can we use case reports, or what are the potential roles of case reports and case series? It can be used to describe the recognition and description of new disease. This is exemplified by the epidemic of West Nile encephalitis in New York City in 1999. Case reports can be used to detect drug side effects. This could be adverse or beneficial drug side effects. Most drug retractions are usually due to case reports. Van den Broek reported in 2006, he looked at a 10-year period to look at drug retractions. Out of the 22, 18 were due to case reports. Sildenafil, which is popularly known as Viagra, was detected as a result of a study that was done, was developed initially as an antihypertensive agent. And it was the side effects they saw during the study that led to the development of sildenafil. There's been a link between nicotine withdrawal syndrome and depression. And as a result of that, that led to the use of antidepressant as smoking cessation agents. A look at the family tree led to the discovery of maternally inherited diabetes associated with deafness. And what that did was to allow medical science to understand or begin to understand mitochondrial diseases. Case reports can be used in medical audits and education. It can also be used in recognition of rare manifestation of disease. It can also have impact on health policy. In 2010, in the United Kingdom, the coroner came to a conclusion that a 70-year-old man that died from an 10-fold overdose of diamorphine the decision was that he was killed unlawfully. And that led to the United Kingdom government to come up with policies to prevent recurrence of those type of things happening in medicine. So I'm just going to describe some reports. Hippocrates and Rufus of Ephesus reported cases of melanoma. Thomas Hodgkin in 1832 described 6 cases, 2 of which is what we now know as Hodgkin's disease. Burkitt's described what we now know as Burkitt's lymphoma, is a tumor usually in the angle of the jaw of African children. And as recently as 1990, Fawcett and colleagues described 2 patients with a new type of lymphoma called hepatosplenic T-cell lymphoma. And this has led to more research in the area. This is the 56-year-old lady who went to the emergency room in Florida Shands Hospital, University of Florida Shands Hospital, for evaluation of right neck swelling that she had noticed 1 month before presentation in the ER. She also noticed a swelling on the right flank a week after the right neck swelling was noticed. Initially, she was evaluated in the community, and the surgeon did a needle aspiration of the right neck swelling. Unfortunately, because of limited resources, she couldn't go back to the surgeon, and hence she went to the ER. Her social history was significant for 30 pack years smoking history and daily alcohol consumption for 30 years. She was also hypertensive, but she did not have any history of weight loss, night sweats, fever, chills. Clinical examination, she had a 6-centimeter firm tender mass of the right neck anterior to the sternocleidomastoid muscle, and also similar size mass in the right flank, and a smaller mass on the left side was also noted. The CT scan of the neck displayed a large centrally necrotic mass in the right infrahyoid neck and additional enhancing necrotic bilateral cervical and superior mediastinal adenopathy. This is the swelling on the right side. And again on the CT scan, this is a coronal view of the CT scan. She also had multiple nodular densities in the lung, and a chest X-ray, CT, was obtained to further characterize the lung metastasis, and they found an additional 3 by 2.3 centimeter mass projecting in the region of the interventricular septum. Fine needle aspiration of the right neck swelling and right paraspinal masses showed only acute inflammation consistent with an abscess. Now that's the interventricular septum. This is in the heart, between the right and left ventricle. The same tumor there. She had a whole body PET scan that revealed diffuse metastatic disease with multiple necrotic masses and lymph nodes mainly involving the cervical and supraclavicular regions. She also had soft tissue deposits in the right lower extremity. And there was also confirmation of the metastatic disease to the heart at the level of the cardiac apex. Increased uptake in the left adrenal gland and focal uptake of the right retroperitoneal peritoneum was also noted. They did a biopsy which confirmed a poorly differentiated squamous cell carcinoma, but they did not know the origin. Because of the extent of the disease, they didn't do anything further for the patient, and that's the PET hypermetabolic metastasis in the lower limb, and that's the one in the heart, interventricular septum, that's the neck. And this is just the squamous cell from the biopsy. This is a 49-year-old lady who was diagnosed with stage 3 nasopharyngeal carcinoma after presenting with diffuse headaches. She was treated with radiation therapy and had cisplatin and 5-fluorouracil. For 18 months, she was disease-free, but she subsequently developed pain in the lower back, and radiologic assessment identified diffuse blastic bone lesions, and a biopsy confirmed a relapsed metastatic nasopharyngeal carcinoma. She had palliative radiation therapy, paclitaxel, and cetuximab, but after that, she also experienced progression after 6 months. They now gave a second line of chemotherapy where she was given gemcitabine. Disease was controlled for another period of 8 months. She initially received zoledronic acid, and this was later changed to denosumab. Disease progressed and now had in the axilla and had iliac adenopathy. She was given a third line of chemotherapy with weekly methotrexate. She had progression again after 3 months. She was treated on a phase 1 clinical trial with a MEK inhibitor, and she had control for 4 months. Again, the disease recurred again. Now she developed a painless mass in the left breast. Mammography identified it as a 5 by 4.4 by 1.9 centimeter irregular mass at the 10 o'clock position and had a BRADS category 5. And that's it. Yeah. PET-CT identified the new left breast mass, and radiographically it was thought to be a primary breast carcinoma. She had a biopsy that revealed malignant cells that are consistent with primary breast cancer, and the immunohistochemistry revealed that it was estrogen, progesterone, and HER2 negative. That's the PET, and that's the CT, the breast mass on the left side. They looked at all the biopsy specimens. It exhibited similar histological appearance, and the primary tumor and the breast mass were EB virus positive. And as a result of that, with all the evidence brought together, the diagnosis was changed that she had progressive nasopharyngeal carcinoma that was metastatic to the breast. At the time of the report, she was still fine, and she was beginning the 5th line of chemotherapy. This is the histology, this is the primary, and this is the one from the breast, so similar type of cells. This is a 16-year-old presented with a 3-month history of pelvic abdominal mass. She had acne, excessive hair, and menstrual irregularities. On further questioning, she had decreased appetite, shortness of breath, and constipation. On examination, she had a diffuse, tender, and palpable abdominal mass extending from lower pelvis, abdomen to the umbilicus. Testosterone, dihydroepione, androsterone, and CA125 were all abnormal, and all the remaining laboratory tests were within normal limits. Ultrasound scan revealed ascites with a well-vascularized mass with cystic and solid components, mostly arising from the left ovary. CT of the chest, abdomen, and pelvis revealed a 13.5 by 23.3 by 21.5 complex cystic and multilocular mass extending from the pelvis up to the mid-abdomen, just above the umbilicus. There were no significant lymphadenopathies in the pelvis and abdomen. That's the mass there, the pelvis. She had a laparotomy, and they removed the left tube, ovary, the omentum, and the appendix. The mass weighed 1,945 grams, and it measured 24 by 21 by 7 centimeters. The cut surface showed multiple nodules separated by fibrous septa. The tumor was poorly differentiated spindle-shaped Sertoli cells forming cords and ill-defined tubules. And the Sertoli cells exhibited nuclear atypia and high mitotic index. So that's the tumor with the fibrous septum. You can see some of the nodules described. This is histology showing the spindle cells. This is 20, this is at 40 times. And this shows some of the Leydig cells, eosinophilic Leydig cells. She was treated with bleomycin, etoposide, and cisplatin, and as a 3 months follow-up, there was no evidence of recurrence. It's a 31-year-old lady who hasn't had any children, admitted to the hospital with a 2-week history of pain in the right lower abdomen and back. An ultrasound scan revealed an 11.8 by 8.3 centimeters cauliflower-like mass on the left side of the pelvic cavity. A CT scan revealed an ill-defined irregular soft tissue mass with extensive calcification in the pelvic cavity. 4 years earlier, she was seen in the hospital, and she had been diagnosed with primary infertility and amenorrhea. She had, on clinical examination, she had age-appropriate normal development of the breast, PBK, and external genitalia. Karyotype was 46XX. Diagnostic laparoscopy revealed absent upper vagina and 2 irregularly shaped uterine bodies positioned near each of the infundibulopelvic ligaments. Both ovaries were normal in appearance. The left kidney was small and non-functioning, and she had scoliosis of the thoracic spine. The only abnormal results was CA125, which was 1870. Normal is usually below 35 international units. At surgery, a 25-centimeter pelvic mass was observed, and there were multiple peritoneal seedings, omental invasion, and rectal wall adhesions. The ovaries were slightly enlarged but normal. So they removed essentially everything, a pelvic exenteration, they removed the omentum, part of the sigmoid colon. Sigmoid colon was resection and blocked. She had bilateral pelvic lymph nodes, and they did a right iliac node sampling and peritoneal washing cytology. This is for staging. At histology, both ovaries exhibited normal histological features, but they had numerous implants on their surface. The pelvic mass contained areas of well-defined ovarian tissue with cystic follicles. And immunochemistry revealed that it was a serous tumor that had developed from a third ovary. So she had 2 normal ovaries and a third ovary, which now developed as a cancer. She had postoperative chemotherapy 6 months after she was stable and did not demonstrate any signs of recurrence. So again, as I described earlier on this, the uterus, both ovaries, the tubes, and had multiple fungating nodules, the largest of which was 1.3 centimeters in diameter. The uterus, both uteri and the cavities had blind ends, and the poorly demarcated yellow-gray tumor mass measuring 8 by 7 by 5 centimeters had invaded the uterine and rectal walls. The omentum was 38 by 5.4 by 2 centimeters. And that's the mass. This is the 2 uteri, that's the cavity there. That's the normal ovary, and this is the abnormal tumor that developed from the third ovary. And histology, this is just the normal ovary, but the deposits of the tumor on the surface of the ovary, and those dots there. This has a higher power. So the diagnosis was a serous papillary carcinoma characterized by thin or complex papillary growths of cuboidal to columnar serous type cells. Both ovaries had normal histological features, but multiple deposits of serous papillary carcinoma. Now we go to rare cases. In rare cases, it's difficult to do a clinical study because these cases occur very rarely, and so it may be almost impossible to do a study. And so what is available for clinicians is that cases that have been reported becomes a template in which they can use to treat their patients if they come across such a patient. This is a 65-year-old male presented with a firm nodule on the left breast and cough of 3 weeks. On clinical examination, respiratory sounds were diminished in the left hemithorax, and there was a firm painless mass at the upper middle quadrant of the left breast. There were no palpable nodes present in the left axilla. There was high resistance in the color Doppler ultrasonography, and mammography revealed a 5 by 4 centimeter mass at the upper middle quadrant of the left breast. Chest X-ray confirmed pleural effusion involving the entire left hemithorax. So that's the mammography, that's the mass. And the pleural effusion was also confirmed by CT scan. There were multiple lymph nodes with the largest measuring 2 centimeters in diameter, and there was a mass invading the left main bronchus, was seen in the left infrahilar region. And then the left breast mass was also seen. So that's the mass invading the left main bronchus. The diameter is smaller. This is just fluid in the right lung. And that's the left breast mass in CT scan. Biopsy confirmed metastasis of squamous cell carcinoma to the breast, and estrogen, progesterone receptors, and thyroid transcription factor were all negative. So this is just necrosis of the tumor. This is the tumor. At bronchoscopy, there was a mass 1.5 centimeters distal to the left main bronchus, and his pathology confirmed squamous cell carcinoma. PET CT showed hypermetabolic masses with high FDG uptake. And there were multiple nodular areas in the pleural origin with high FDG uptake. So again, that's the mass there. That's the one in the bronchus, all light up. And the PET scan. And this is the whole body scan. This area in the pleura initially was suggestive as if there was some metastasis there, but when they did a biopsy, it was just pleuritis. They didn't find any metastasis there. So examination of the pleural fluid was consistent with empyema, and the disease was stage 4. The patient was treated with chemotherapy and radiotherapy, etoposide and cisplatin. Unfortunately, he passed away 6 months after the diagnosis. A 28-year-old lady, don't have any children, had a 14-month history of abnormal vaginal bleeding, had a past history of hypothyroidism and epilepsy. 2 months prior, had a diagnostic uretide that revealed a diagnosis of endometrial adenocarcinoma with glandular squamous metaplasia. She had an exploratory laparotomy that showed a large omental mass and diffuse miliary nodules in the pelvic peritoneum. Biopsy confirmed endometrial carcinoma with yolk sac tumor-like differentiation. She was treated with paclitaxel, adriamycin, and intraperitoneal cisplatin. She was referred to another hospital, and laboratory tests said she had high levels of alpha-fetoprotein and beta-HCG. and CA125 was also high. Chest X-ray was negative. She had a total abdominal hysterectomy. Both ovaries and tubes were removed. She had pelvic lymphadenectomy, omentum was removed, appendix was removed, and she had partial sigmoidectomy. Uterus measured 10 by 8 by 5, and the cavity was filled with a cauliflower-like tumor measuring 6 by 3 by 2.5 centimeters. So that's the tumor there, that's the uterus. Pathology confirmed a moderately differentiated, well to moderately differentiated endometrial adenocarcinoma with yolk sac tumor-like differentiation. There were no trophoblastic components. So there's a transition between endometrial adenocarcinoma and yolk sac tumor. The metastasis, the histology was similar, and the myometrium, cervix, appendix were all negative. The periodic acid shift test was positive, and immunohistochemical analysis revealed that both endometrial adenocarcinoma and yolk sac tumor components were positive for AE1 and AE3. Yolk sac tumor was positive for alpha fetoprotein, while the endometrial adenocarcinoma was relatively negative. There were focal positive staining for P53, and estrogen and progesterone receptor was negative. So this is AFP positive, and so this is the yolk sac segment, and this is the endometrial carcinoma side of it. 2 days after surgery, the alpha fetoprotein and beta estrogen levels decreased dramatically, and CA125 dropped to the normal range. She was treated with 6 courses of paclitaxel and carboplatin, and 2 additional courses with etoposide, methotrexate, actinomycin D, and cisplatin. 2 or 3 months after, beta ECG and alpha fetoprotein levels increased, and despite treatment with 2 cycles of fluoxuridine, dactinomycin, etoposide, and vincristine, the levels of alpha fetoprotein and beta ECG increased. She was lost to follow-up after further treatment with oxaliplatin and cyclophosphamide. Now, our case reports important in the era of evidence-based medicine. Some people advocate that it's a waste of time, case reports don't do anything, and that they don't contribute anything to healthcare in the age of evidence-based medicine. But we all know that a single report cannot provide evidence of efficacy or safety in the diagnosis and treatment of a disorder. Albrecht and his colleagues looked at 100 published case reports in the archives of dermatology, and they expressed concerns about publication bias in support of positive results, exaggerated claims of efficacy and safety, inadequate informed consent reporting, and underreporting of patient-centered outcomes. From a business perspective, case reports are rarely cited because they kind of impact they negatively affect the impact factor of a journal. And a journal having a high impact factor can be a decisive factor in authors considering which journals to submit to, and also how companies determine the allocation of their advertising budgets. So evidence-based medicine exclusively finds the best evidence for clinical decisions. For example, what therapy or diagnosis test to apply to a particular patient. A randomized clinical trial serves one purpose admirably: the final evaluation of therapies or tests, especially when their clinical value is not immediately clear-cut. However, case reports have other aims that are equally important in the progress of medical science and education. we can look at meta-analysis or systemic reviews of case reports or case series. Mayfield and Gorin, they retrieved 21 cases of tamoxifen-related ocular toxicity in breast cancer patients. As a result of that review, a clear picture of the nature and distribution of the toxicity and the severity of the ocular findings was made. And they also discovered the difficulty in attributing ocular findings to either tamoxifen or other competing causes of retinal, macular, or corneal abnormalities. Norden and his, looked at a 20-year literature review of primary carcinoma of the fallopian tube. Again, that review led to a more appropriate patient characteristics. They were able to hypothesize on the reasons for underdiagnosis of cases, what were the causes of treatment failure, and the usefulness of a second look laparotomy for monitoring disease response to the treatment given. We looked at herbal therapies used by cancer patients. 18 of the case reports had apparent anti-tumor effect, and 21 cases had toxic effects. There were clinical trials in agents like green tea, phytoestrogens, mistletoe, silymarin, and the others. PZ spares and saw palmetto also had been studied prospectively, but what we concluded was that many of the herbs that had promising case reports findings have either not been explored or are not reported in English, because this was only in English reported cases. So we know that case reports, what it can do is to give us the characteristics, and case outcomes is what can be assessed at this level. However, in situations where the evidence is not adequate, the best of the first line of evidence must be taken into account. What impact can case report make on medical research? Just want you to focus on case reports that were followed by published trials. This is just 64 case reports. Find that at most of it, only 17% here and 83% wasn't done, said no. And the outcome, when you look at, improvement, most of the reports suggested that there was an improvement in case, an improvement for the patient. Now this is case series. Looking at a similar thing, case reports that were followed by published trials, slightly higher percentage here compared to the cases. And also, when you look at improvement, again, a high percentage. How do you write a good case report? There have to be a single message, must be clear. Why is the observation important? What does it teach us? Does it run counter to some cherished truth? Is it an unexpected association? Is it a rarity that would otherwise be missed? Case reports should be written in an organized and structured manner, and definitely is still relevant in current day medicine. And in rare instances where clinical trials are not possible for ethical reasons, case reports or series may be the only evidence available to recommend treatment. Over the last few years, there's been a lot of, an increase in number of journals that report only case reports. So there's been an improvement because the mainstream journals, most of them don't accept case reports. So they have case report journals now. Thank you. Any questions?
So are there online journals now for case reports?
Yes. Yeah. There's one in cancer. There's that reports only cancer case reports.
Are the case reports generally reviewed by peer reviewers?
Yes. Yeah, they're peer reviewed. And now there's a lot of emphasis on consent, because long time ago people just took pictures and just wrote, they wrote the cases, but now they have to be consent. by the patient. So
Okay, well, thank you very much.
thank you.
Pleasure.